can hear me at the back, I think so. I haven't got the school teacher voice of John, I'm afraid. And we don't need the projector, so you don't need to bore yourself with PowerPoints. So prostate cancer. I've been a consultant in the NHS for 38 years, and I've always looked after prostate cancer patients. And I ran the main clinic at Hammersmith for many years. And my most famous patient ever with prostate cancer was, of course, the Lockerbie bomber. I don't want to talk about that tonight. I will if you want to later. Prostate cancer is a very enigmatic disease. It's a very difficult disease. It's the most challenging of diseases for an oncologist. And the scenario in the early discussion is just amazing. We can do nothing, we can just watch you, we can radically remove it, we can destroy it with radiotherapy. There are different types of radiotherapy. There are other new drugs out there. There's a guy that wants to heat it up down the road. There's a guy that wants to laser it out at the other part of London. What should you do if you get it? And what do you advise your spouse to do if they get prostate cancer? There's no other cancer like it. If you go to 100 different oncologists and get opinions, for most cancers, you may get one or two options, and you could form a balance. You can also find them on Dr. Google, if you consult Dr. Google. It's fairly clear, but for prostate cancer, it's not clear, and that's the problem. There are also other areas in prostate cancer which are completely mysterious. The biggest problem is why Mr. Jones comes to your clinic with exactly the same pathology, the same MRI, and he dies of his cancer a year later. Mr. Smith, exactly the same pathology and everything, lives to be at 98. And that's the enigma in the whole thing. We can't predict at the moment. It's going to change, it's going to get much, much better, but at the moment we can't do it. So we have no way of advising people what's really best. And there's all sorts of things out there. I'm sure you all know, being a very prostate-aware audience, and I'm sure the ladies are prostate-aware as well, even though they don't have prostates. A common fallacy for medical students in multiple-choice questions. They're not that, or maybe at Oxford they're a bit bright. The problem is that we just can't tell the difference between an aggressive cancer and a non-aggressive cancer. The problem with prostate cancer is you don't die of local disease. You die because the disease spreads, a process called metastasis, Greek, I think it's Greek, maybe Latin. You're the linguist, John.
Greek,
yes, okay. Meta, change, stasis, place, a change of place. And prostate cancer cells like to go to the same old places. They like to go to the bones, especially for some reason up the spine right to the top, into the ribs, and then sometimes into the nodes just above the prostate and the pelvis, and then up behind the abdomen into the lymph nodes, and then into the bloodstream and into the lungs, and sometimes into the brain. And prostate cancer is a slow burn type of cancer in most patients. The average age of a cancer patient with prostate is actually 72 years in Britain, which I thought was incredibly old. I'm getting there myself, so getting to seem quite young, actually, 72. But most cancer patients, especially women with breast cancer, tend to be in their 50s and 60s. So in the prostate clinic, I feel like a young man again, because everyone's older than me. But that, as I say, is beginning to change, unfortunately. So the problem is that as we can't tell who has the most aggressive type of cancer, there are some hints, which I'll come back to. We have to treat everybody with a set protocol. And increasingly, medicine in all parts of the world has got protocolized. You follow algorithms to treat people, put data in, and the computer tells you what to do. The problem is that for prostate cancer, even the computer can't really tell you what to do. And then, of course, we live in a totally different medical world than I was brought up in. When I was a student at Cambridge, and then I became a consultant at Addenbrooke's for my first 5 years as a consultant, we didn't tell people I had cancer. It was just unbelievable. Some of you will remember if you had family members treated 30 or 40 years ago, we just didn't use the word. There was no Oxford Cancer Centre, there was no Prostate Cancer Society, prostate support group, didn't exist. Why? Because people didn't get told the information. You've got cancer. It wasn't spoken about. The media didn't talk about it much. And if a film star, a celebrity got it, there were no celebs as they are now, everyone's a celebrity now, but if there was a film star that had cancer, it wasn't mentioned what they had. And we lied to people. We actually told complete lies. Women with breast cancer, I remember, would have cysts that would be treated by radiotherapy to make the inflammation go down. And people believed it. Sometimes if the disease has spread, the metastasis, we'd tell the relatives that their close relative sadly had cancer, but not to tell them because they wouldn't be able to handle it. And that is in one generation of a doctor's practice. So all changed now. The internet's changing it again. And so we live in a world that is totally transformed. So where's it all going to go? Now you're a very young group, you're nearly all well under 72, I can see. Average age probably about 58, 55 for the men and 35 for the women. I must change my glasses again. But, where's it all going to go? And I see it going in 4 ways. The first way is the technology. The technology is changing quite dramatically. So we've been stuck with the PSA, and I know you all know what the PSA is, for the last 50 years. And it's not a great test. It's useful to follow someone up. So people have surgery, radiotherapy, they come back to the clinic every 3 or 6 months, and you do the PSA and you can tell if the disease has come back or not. But it's not good to screen people. And the reason it's not good, there's lots of reasons why the PSA goes up. And I've got a close friend of mine at work who actually had an alarming PSA. He did it for fun. He's a physician, and he had to get some hepatitis tests because you have to have them every so on to show you're immune to hepatitis. And he ticked the PSA box. This was a bad mistake. And it came back as 15, which, as you know, the upper limit's 4, and obviously it goes up with age. But above 6, you really need to look at it. And his was 15. So he was sure he'd got prostate cancer. And to this day, psychologically, he's been crippled by that discovery. He's never developed, the MRI's completely normal. He's even had a biopsy, and that's completely normal. But it shows how bad a test it is as a screening test. It's not a bad test if you have symptoms. If you go along because you're getting up in the middle of the night more than usual, and you go along to your doctor, and the doctor then says, right, you have a PSA, but that's not really screening because you've gone to the doctor with symptoms, and that's a test given to see if you've got prostate cancer. And then the whole world of the future is going to be about developing better blood tests, not just for prostate, but for a whole range of cancers. And ultimately, a GP surgery in 25 years' time, you'd go along, you'd have any cancer-related symptoms, a finger prick test will be put into a machine that looks like a diabetic machine and have a little black box, and you put it with a needle, the blood sample's taken, and you get the blood sugar almost instantly. You'll get some very complex molecular information almost instantly out of the black box that tells you that you have cancer and the likely organ that it's coming from. And maybe even more information, whether it's likely to spread, what the grade of the tumor, how aggressive it's likely to be, and even the outcome. And then how to treat with different things and what would happen if you're treated with different things. And that's, we live in a world where you can't breathe. Every day I see the words AI, and it's not artificial insemination, it's artificial intelligence. Everywhere I go now I see it. I walked from the station, I walked past the bookshop, the famous one, Blackwell's, and there, staring me in the face, all these books about artificial intelligence. Where it's going to be used in medicine is exactly the complex problem of diagnosing cancer and guiding the best forms of treatment in something as complex as prostate cancer for an individual patient. So the future of diagnosis is instant blood test, or even better, buccal mucosa testing or urine testing for cancer. And better markers than PSA, to segregate the bad guys, the really bad, aggressive cancers, from those that are never going to trouble you. At the moment, if you're 72, you have, on average, 12, and reasonably healthy, as a man, you have 12 years left to survival, 84, if you're 72 and reasonably healthy. So you get prostate cancer at 72, then if we could keep you alive without trouble, without any pain, without any urinary problems for 12 years, you're essentially cured If you're cancer, you're going to die of something else. If you're a woman, you've got another 2 years after that, 86 if you're 72. Prostate's not a disease of women. So basically, it's all about controlling it. Now, if you have the information how aggressive a cancer was going to be, you could tailor your treatment to that individual. And that's what's meant by personalized medicine, or the Americans often call it precision medicine, targeting sometimes very expensive treatments, whether they're protons or high-cost drugs, to the patients that really need them, and avoiding those that can go perfectly well, surviving a long period of time without any treatment. And that would transform the way we do medicine, not just for prostate, but for the whole of oncology. So personalized medicine is based very much on what you read about genomics, the understanding that here we are in the room, here we are 60 people in the room, we all got totally different DNA. The reassuring thing is 99% of it's the same, so in fact 98% is the same as a mouse. That's a horrible thought, but never mind, that's the fact. And if we, for about £200, we can put your DNA onto a USB stick. And in itself, that doesn't tell you anything. But if we have a large database to look at, we can begin to see signals. And if we have the cancer DNA from a biopsy and your DNA, and we have a big data set, we can identify how your cancer is likely to behave in you. So anything that gives information about whether a prostate cancer or metastasize will spread is very useful. So if you think of it, you're sitting in the clinic, a man comes along with prostate cancer, and you put all the information together. The missing bit is what's going to happen if we do nothing. If nothing's going to happen, if the tumour's just going to stay there, PSA will go up maybe a little bit, there'll be new markers, much better, more sensitive markers. The minute it starts going up, we can actually intervene. So watchful waiting will still be very much part of the future process. Now the problem with watchful waiting, it's psychologically difficult for many people. Here you are, you've been conditioned by public health messages that cancer kills and cancer that's delayed kills, and that's true. And that the best way to treat cancer is aggressive, and the first time you treat it's the bite of the cherry, and all these phrases that are used. And here you are being told by your oncologist, no problem, watchful waiting's for you, just come back in 3 months and we'll do another MRI, and then we may do some more blood tests and so on. If the blood tests were better, it would be much easier to convert more people to watchful waiting. I remember a TV film on cancer, a series of programs that I was asked to review technically. And they had General Schwarzkopf, if you remember, he had, the American general had prostate cancer. And he said the wrong thing. He said, we got to get this disease early, and we've got to get the PSA. Why leave it? And we've got to blast it. You know, no collateral damage and all the other phrases. Very nice. But that's not quite how it's supposed to be. So I said, can't we just take that bit out? I said, no, it's great television, this guy talking like that about his cancer. And that's the problem. It's a sort of misunderstanding in the whole system. So the future is going to be getting rid of that misunderstanding and identifying the cohort of patients in whom watchful waiting really would be beneficial. If we then go on to the future of what else we do, if we know that the tumour is likely to grow and spread quite rapidly before the 12, 15 years lifespan left to a person, what should we do? We should destroy it locally. And as you know, surgery is one way of doing it. In the old days it was done open surgery through the front, a little incision, transverse incision in the front of the pelvis, and the prostate was brought out, and a radical prostatectomy was the treatment of choice. The trouble with that, it damaged nerves. It damaged nerves, sometimes the bowel, sometimes the urethra itself, which goes through the tube connecting the bladder to the outside world. And all these things cause unpleasant side effects. And as you've all read, the most unpleasant side effects of surgery, and indeed any other local treatment, are either gastrointestinal, which is the rectum being radiated, the small intestine being radiated or interfered with surgically, genitourinary, so impotency, difficulty in getting an erection, and difficulty in passing water after operation. And then other ones such as hips, getting fractured hips because of various things with radiotherapy, not with surgery. So with surgery, the big advance came 10 years ago, which turns out not to be so much of an advance, and that's robotic surgery. Now, robots are very good, and it's all fun to demonstrate robots doing surgery in a distant continent. And I remember seeing a gallbladder being taken out of a conference, a cancer conference in Atlanta, and the gallbladder was being taken out in Moscow. I mean, it was just a gimmick to show it. So the guy was controlling it, and you could see in Moscow the gallbladder coming out. So, but for certain parts of the body, minimally invasive surgery, which is called traditionally keyhole surgery, is beneficial, damages less tissue. The problem is that for prostate cancer, there have been several studies now which show that robotic surgery is really no better than conventional surgery in terms of all the side effects and the long-term survival, long-term benefits. And that's a bit of a puzzle because it should be. Robots are always better because they're computer controlled. And you know, a drunken urologist or a urologist with a hangover is not the man you want to explore with your pelvis at 8 o'clock in the morning the next day. We've been on a binge at the hospital bar or the golf club perhaps. So basically trying to understand why robotic surgery was no better is a bit of a mystery. But it probably just reflects the fact that a very good surgeon that's got lots of experience, and the surgeon to pick is a younger person, and the best age to get your surgeon for a prostatectomy is between 40 and 50 years old. Above 50, they're a bit wobbly. Below 40, they're using a book to instructions. The same goes for radiotherapy, by the way, but less so because old boys are good at radiotherapy. That's what I'd like to say. Ken from Reading is a young radiotherapist, and I'm an old radiotherapist. You should come to me, not him, especially if you're a private patient. So basically, surgery is moving forward, but where it's going to move to almost certainly is getting the image. One of the biggest advances throughout the whole of cancer in my professional life has come really by stealth, and that's imaging. Being able to see the anatomy of the inside of the body painlessly by, first of all, CT scanning, then magnetic resonance imaging, and then also with PET scanning. And I can remember the day in 1975 I saw my first CT scan. I was a registrar at Cambridge and put this up on the thing. We'd never seen a CT scan before. And you suddenly saw the anatomy beautifully outlined. And you could see that was a step change in the whole imaging process. From very messy barium studies, very messy x-rays done at right angles, and you looked at them and you drew where you thought the cancer was, but it was a very messy business. Once you saw the CT, you knew that was going to be the future. Because also, the data in a CT is mathematical. Every little dot you're seeing, it's called a pixel, has a mathematical formula attached to it, which means you can manipulate the data in there. So if you want to put onto it a radiotherapy plan, when I started, the radiotherapy plan would come on by putting a stencil on the X-ray and trying to work out what was going on. The computer had all the data of each little pixel in mathematical form, so it could easily calculate not just one plan, but thousands of plans. And if you taught the computer, it could pick the best one for that patient, for that type of cancer. And so that's really the future. It's going to be all about getting more information out of images, blending them together, and we already have what are called fusion programs for CT MRIs and PET CTs, and then making sure the outline of the cancer is in the right place. And so surgery is probably reached its peak. Radiotherapy has not quite reached its peak. We're going to get more technology in there. And really protons, which we're setting up now in the UK, is just part of that technology. And maybe I should mention protons in the technology box now. So protons were discovered by Ernest Rutherford in Cambridge, much better university than this place. And 1917, although he postulated them in 1911, and he got the Nobel Prize in 1922. So basically what he discovered was within the hydrogen atom there was a proton, and an electron, and they wandered along. And I've got to tell you a proton joke, because that's all you hear at proton conferences. So the proton's wandering down the street, and he realizes he's lost his electron, so he's no longer a hydrogen atom. So he goes up to a police, and the proton, of course, is positively charged. So he goes up to a policeman and said, "I'm terribly sorry, but have you seen my electron? I want to report it missing." And the policeman, "Are you sure?" And the proton says, "I'm positive." So the attraction of protons is that they stop at a defined point, and you can control where they stop. William Bragg, another Cambridge physicist, discovered what's called the Bragg peak. As a proton enters tissue, it stops at a defined point, and beyond it, there's no energy transfer, so there's nothing beyond. With conventional radiotherapy, and I'm sure some of you in this room must have had conventional radiotherapy with a linear accelerator, the radiation goes right through you. It produces what's called an exit dose. And so in certain parts of the body and in certain patients, there is an advantage to protons in terms of the distribution you can get. And Schwarzkopf would understand this. Collateral damage is the military expression for when you throw a missile, you've got an orphanage next door, a hospital on the other side. You're trying to get the bad guys in the middle and not the hospital and the orphanage. And the trouble is the bad guys hide amongst the orphans and the hospital patients. It's the same with cancer cells up to a point. But basically, collateral damage is, in some circumstances, much worse with conventional radiation than with protons. There's nothing fundamentally different about a proton depositing its energy, and it's one of the problems that people often think, if I get protons, I'll be cured. If I get conventional radiotherapy, I won't be cured. It's not like that. What we have to do is to get the best possible plan to distinguish between the cancer and the surrounding normal tissues. And so, again, the computer's taking over with all this. The computer can instantly do a comparison. The doctor still draws on the outline of where he or she wants to radiate, and the computer can work out the best possible type of radiation to give. And so, protons are coming into being mainly because the machines have got cheaper. And that's been the driver force of any disruptive technology, wherever you are, the automobile industry, the aeroplane industry and so on. Things get cheaper for a variety of reasons, and protons have got significantly cheaper. At the moment, they're about double the cost of conventional radiotherapy, whereas 5 years ago, they were about 10 times the cost. It's not likely to go down anymore. The compact machines that are now marketed are as effective as the big machines, and they're a lot cheaper. Not just the machines themselves, the size of the building smaller, the size of the protection to the outside world smaller, so they are much more cost effective. So basically, why I've got involved in protons is I've been in conventional radiotherapy all my professional life, and it just struck me this is an area 3 or 4 years ago that it needs something to happen. The NHS, Andrew Lansley, who you remember and love, I'm sure, was the health minister in 2011. He announced NHS would have a proton plan. And the plan was to build 2 facilities, one at the Christie in Manchester and one at UCLH in London. And the problem was that was predicated on the 1% of radiotherapy would be delivered by protons. Other European countries, all of which have now got proton facilities, we're the only country, well, until last week we hadn't, now we have. Basically, we're planning on a 10 to 20% conversion of radiotherapy to protons. So we decided we'd go to the city and get money from an Oxford-based group to start with, Neil Woodford, who's a fund manager very famous in the funds world, and set up Proton Partners International. The centres are called Rutherford. We're building one in Reading, where Adele is developing it for us. And Oxford has a strange history of protons. They bid for the government one, the NHS one. The bid got turned down. It went to Christie and UCLH. And they still want to get one, but unfortunately it just hasn't happened. And it's unlikely now, with one at Reading, it'll happen. So we're building 5, one in West London, Reading, Liverpool, Newport in South Wales, which is next to Cardiff, and we're looking at various other locations as well. for the future. What's it mean for prostate cancer? Well, it's complex again. It's almost like the whole business of the robotics and the PSA. Everything you do with prostate cancer is not simple, if only it were. And almost certainly the way to distinguish between someone that would benefit from protons compared to photons, conventional radiotherapy, is to plan them for both. The computer can do it and then see if there's any benefit. And the organs around the prostate that are at greatest risk are the rectum. People get awful rectal problems late in life, 20 years on afterwards, and the bladder, the small intestine, and sometimes the large intestine. So anything you could do on the radiotherapy plan to avoid these critical tissues is what you need to do. At the moment, the NHS is sending about 300 patients a year abroad, mainly to Florida, Jacksonville, and very good centre. I went round there, nearly all children and a few adults with base of brain tumours. And the reason for that is that we know that in children, the tissues around the cancers in the spinal cord and the brain are very critically radiosensitive. And they're likely to survive, which is the good news. They're likely to be cured. And therefore, you don't want them to get the long-term toxicity of conventional radiotherapy, which can be avoided with protons. But gradually, as we get more experience with other tumours, including prostate cancer, protons will come in there, and probably around 20% of men with prostate cancer, if they're having radiotherapy, would benefit from protons. The challenge is, just like with chemotherapy, to identify which patients would benefit most and only give it to those that would get real benefit. So that's the technology that's moving forward. The other thing that's changing in the cancer world is society. And the biggest change that I've seen is the information. This group would not have existed, as John said, it didn't exist 7 years ago. We wouldn't talk about it publicly. The doctors knew all about it, and gradually there was Milan, Cancer Research UK became very public about cancer. I have two of the best sites on cancer. They're very different, but they're both very informative, and we all use them in the business. We all use the data, especially the Cancer Research UK site is full of all sorts of very good quality data which is updated regularly. So society is changing more now, and I think consumerism, openness, I can't get used to it, but the mobile phone and apps and for cancer are all out there now. Maybe that's for a different generation to take, but the millennials are certainly using app doctors and so on down the line. And maybe we should be more positive about that for cancer and for diseases like prostate cancer. I think the other question is, the third part of the future is where we deliver cancer services. And at the moment they're delivered in cathedrals of medicine, like the Churchill across the road there. The ones in London have saints' names, as you know, St Thomas's, St Bartholomew's, and St Mary's, and so on. And that's because medicine and religion were connected in the past when these hospitals were founded. Bart's was founded by a monk right here in the 9th century or the 10th century. And so the technology was all concentrated in the big university teaching hospitals. But that's no longer necessary. You can take the technology out and put it where people live. A bit more complicated with the Proton Centre. It's a bit big, and not only that, it's a bit expensive, like £30 million, so you can't perhaps move them everywhere. But you certainly can do it with conventional linear accelerators. And you don't lose the expertise of the centre because you have good quality assurance, you have good information technology to connect everything up on networks. And that's going to be the future. Same thing for chemotherapy. Every small town in England should have somewhere you can get chemotherapy. Cancer is a disease for life for many people. They're going to go on for many years successfully being controlled, just like diabetes. So you want to make it integrated into their lifestyle. If they're working or if they're retired with families and so on, you want grandma to keep giving you the childcare. That's how I feel with my grandchildren. I can't get hold of my wife, she's always looking after children. So I think that's the important thing, is embracing cancer as part of a normal lifestyle. And then I guess the fourth box of the future, which is a real problem, is how we pay for healthcare in an ageing population. And you know, we're not alone in struggling. I mean, Britain has got one system, the NHS. Other countries have social insurance. America has a free market with sort of bit of social insurance. Very difficult to work out. there's no doubt healthcare is going to go up and up in price, and we're not paying enough into it in probably any country. America is 1.9 trillion. It always goes up when I hear a figure for healthcare in the States, but there's no way that even they are paying enough for healthcare in an aging population. And as you know, health and social care are inextricable. You can't separate them out. And you know, the problem in a completely free service is you can't dampen demand. It hasn't got the levers to allow you to dampen demand, and that's the difficulty. And sure, the difficulty is if you say, well, I'm going to charge £10 to go to your GP, it's not worth it. It's not worth collecting the money, because you're going to exempt children, you're going to exempt people over 65. And if you look around most GP surgery, most of the people are my sort of age in it. So if that's the case and we're exempt, you're not going to collect any money for a lot of hassle for the receptionist. So huge challenge for us all. Maybe a huge challenge for the next generation. That's the great thing about it, because we'll get through our lives okay. It's the next lot, they're going to have to pay for it. But the majority of patients are controllable. Hormones, drugs. There are now 5 new drugs out there for cancer, prostate cancer, all approved. Sometimes you can get them on the NHS, sometimes not. There are various schemes to help you get them, but they are expensive, £40,000–50,000 a year. We've got the whole of immunotherapy opening up. That's £120,000 a year. No healthcare system in the world can afford to do that. Protons at least double the price of conventional radiotherapy. Who's going to pay for it? I think anything we can do to tailor the treatment to the right patient is for the benefit not just of that patient, but the benefit of the healthcare economy as a whole, because you won't be wasting money and giving people stuff that's not going to help them at all. So I think we're going to hear more about personalised medicine, more about protons. I must say our relationship with the NHS Proton Committee is not the greatest. The NHS Proton Committee has a rigid list of 1%. They're sticking to their 1%. It's got to fall apart, because it can't be that in France 10% of people are getting proton radiotherapy, whereas in Britain only 1%. And at the moment, we're the only ones giving it, because we're the only ones who are a centre working in Newport in South Wales. So I think the politics will gradually fall away, and I think it'll be very interesting to see the long-term benefits of proton therapy for prostate cancer, some other new treatments coming along, and how we can factor in predictive testing to make it a much more easy to control disease and make life easier for people with prostate cancer without some of the dreadful symptoms. I finish off with a little anecdote. I was a cardiology houseman at Hammersmith a long time ago, and I worked for the professor of cardiology, who was a very nice man. He was very aggressive and very loud, and had big thumbs and big fingers, and it was very nerve-wracking working for him. I did it for 6 months. He rotated through cardiology, only 6 months. It was great. And about 20 years later, I was in my office, the phone went, and it's Shillingford here! And I just instantly stood out, a voice of a blast from the past. And he said, I've got prostate cancer. I need a spot welding with your magic toaster. Not quite how he describes sophisticated modern radiotherapy, Professor. And he came along in a taxi, a mini cab, and he kept it running. I said, well, we're going to have to plan it. No, we can just do it all now. I'll point to where the pain is. Just give me a shot there. And we did. The radiographers were all very amused, because normally plans. I just took him into the simulator, marked the spot, and took an X-ray and get treated, one treatment. And he was so grateful, it was better. And we did this for about 10 years. He phoned, and we didn't want any follow-up, didn't want to talk, didn't want to join your group, John, I'm afraid. Just didn't want any leaflets. He just wanted, when he got pain, he'd want to come and do it. And the last time I saw him, he was 86 when I last saw him. I went to his house in Barnes on the way home to Beaconsfield. It was a bit of a deviation. And he'd always have a bottle of champagne when I go there. You have to drink half a bottle of champagne and then face the A40 at 8 o'clock at night. And he'd say, you know, Sikora, I've seen in the papers you've been criticising the NHS. My treatment was pretty damn good, I thought. So, there you go, you can't win on everything. Thanks very much.
Sort of 5 seconds to take a deep breath after that fantastic presentation. I know there will be lots of questions. Can I just start out with one, Karol? You said at the end, proton treatment, how are we going to pay for it? Well, you have 5 centres developing and 1 already running. So who is paying for treatment and how are they paying for it in the one that is running?
So the Welsh government put £10 million into the first centre. That's why it's in Wales, by the way. And they're nationalists. So they said this. I hope no one's got too Welsh here. They're very nice people, but they said we want you to fire the beam before England. So there, it's a separate fund. And so what we're doing with them is they're using the NHS England criteria for protons and then paying for us to treat them there. Otherwise, they'd have to go, at the moment, they'd have to go to Jacksonville, and the cost there, just the basic treatment costs are more than double what we can charge in Newport.
So the patient is not paying?
The patient's not paying in Wales. Yeah. And we've got contracts now with all the main insurers to pay for protons for insured patients, and obviously international patients self-pay. I mean, the biggest problem is dampening the expectation that protons are good for everything, and they can't be. If you have metastatic disease, whatever it is, there's no point coming for protons. And it's inevitable, even when we have 5 centres and the NHS has 2 centres up and running, those getting proton, on the whole, will have further travel time, much greater travel times to get there, and it involves staying in hotels. And so you don't want, that adds to not just the cost, but it adds to the trouble of having radiotherapy.
Dave, and for those who don't know him, this is Dave Beasley, who's our president.
There's 2 questions I want to ask, but the most important one is, when we talk about this proton, would that be with Professor Mark Pemberton up in UCL? Yes.
No. He uses a different type of, he uses heat treatment and laser treatment rather than protons.
Okay, the other question, quickly, is Al McCready, the bomber, one of the good things he did give us was abiraterone. Because when he was released from Scotland with weeks to live, he got back to Libya and they put him on abiraterone.
It's an ironic story,
He
yeah.
carried on living for 4 years back in Libya. Yeah. And abiraterone, as we know, is made in the UK. And many of us fought by going up to the Houses of Parliament to lobby the MPs to get abiraterone agreed by now. So I just thought I'd share that.
Yeah, no. So he actually lived 3 years, but not in great nick for the last year in Tripoli. But the fascinating thing about it, I was one of the team that were asked to assess him, and the criteria they wanted is 3 months. If you think he's going to die within 3 months, we can let him go on compassionate release without going to jail in Tripoli. So after a lot of haranguing, we signed the papers, and the next day this cavalcade, him going out of Greenock jail to the airport, and went back to Tripoli. And you're right, the plan in Glasgow was to give him nothing. He's got widespread bone metastases everywhere, and he was young, he was 52, 53, so he had and all the criteria were very aggressive. And so, you know, it's when you ask what the treatment plan was, this is too much of a security risk to take out of prison. So he wasn't getting chemotherapy, he wasn't getting abiraterone, that wasn't available on the NHS, as you say. And the minute he got back to Tripoli, it became a cause célèbre to keep this guy alive, to show that they could do it. And they had American doctors come in, they had German doctors come in, and they kept him going for 3 years. But you're right, it was a British drug, paid for initially by the Cancer Research UK for the development cost, then taken over by the pharmaceutical world, and then not available because of NICE for several years afterwards. And in an erratic way, it comes in erratically around the country. So maybe he did us a favour in getting it and surviving it. But it didn't do me any favours. Everyone thought I was getting bribes from Libya. So
I have maybe a point, which is that you talked about there's no way of distinguishing cancer from aggressive to the benign. Well, and I could have got my facts wrong here, but about 9 months ago, we had a research team here from Oxford University who said that they developed these markers to identify at least 3 types of prostate cancer.
Yeah. There are some markers, but none have gone the test of time. That's the problem. The best one is actually the biopsy. When you get the biopsy, the pathologist looks down a microscope and you use a very, very old-fashioned thing called the Gleason grade and the Gleason score. And it's a very complex and unnecessary so, but it's stood the test of time and no one wants to take it away. It's the only cancer we have such a complex grading system. And there's no doubt it goes from 1 to 10. No one's 1 and no one's 10. They're all in between. And the average is 7 or 8. And if you're 9, the tumour's likely to be more aggressive. If you're 6, it's less likely to be aggressive. But it's not perfect. And it's difficult to base treatment decisions only on that.
Right, but that's not based on
New
on
work.
markers, right?
Yeah, exactly.
On
Yeah.
personalised genetic markers. Where my understanding is this team that came here had developed this.
Yeah, that may be the case. And there's lots of research. I think that the trouble is not yet in routine practice. And so we need large data collection, and we need to wait 2 or 3 years before you can see if it really does what it says it does. And that's the problem with any new test. And of course, the media, especially the Daily Mail, love new things for cancer, and they're always writing about them. But often they haven't stood the test of time to know if it's going to be valuable.
But now, if that research
that would be very useful.
then that's going to radically
It would change the way we
change
practice.
your approach.
I was diagnosed recently with prostate cancer. In fact, I'm having a prostate removed this Saturday, rather earlier than I was originally told. Robotic keyhole surgery, which my understanding had been rather more precise and sort of less risky than open surgery. But from what you said, perhaps that isn't the case. Don't you just comment a bit further on that? But my other question is, this 1% in the UK for proton therapy, 10% in France. Why is that a cost thing primarily, or does the government, the NHS, have some other agenda here?
I mean, I've got a slide which I could show you, which shows my secretary is very good at making slides. She's a lot younger than me, and she's got little flags of all the nations and their government, their healthcare systems predicted proton use. And we're just an outlier at 1%. America's another outlier at 20%. Everyone else is between 10 and 15%, all across Western Europe. Now, why should this be? It's because Lansley made the announcement in 2011, and that was, sometime 7 years ago. The workup for it was done in 2008, 10 years ago. And then it looked as though 1% may be realistic, but now as more data's come, it looks like 10%. Well, 10% would mean 18 facilities in the UK, and there isn't the money to build them. Not only that, they take at least 2.5 years to build. In the case of UCLH, it's going to take about 7 years to build. And so it's a very difficult situation with new technology. A new drug would be easier to deal with because here it is in a bottle or in a syringe. Whereas with this, you've got to get the building up, you've got to do the training, you've got to have the mentorship and so on. So it's a bit more complex as a project.
Could I take up the question's first point about robotic, because I was interested in what you said, that robotic surgery was perhaps not that much better than open surgery. The feedback that we've heard from men in the group who've been in your position, because we started 7 years ago, they weren't doing robotic surgery in Oxford then, so any man who had surgery, it was open surgery, which is what I had. The feedback I've heard from people calling in is that one of the things is the recovery period is much quicker. I always quote the case of, some of you will know who I'm talking about. We had our winter Skittles evening about 4 or 5 years ago, and the door opened and Dave said, "Oh, here's Chris, he had surgery 3 days ago," and I thought, funny joke. But he turned out he would come to the Skittles evening 3 days after his robotic surgery. He would not have done that after open surgery, I can assure you.
He actually won a prize as well.
Yes.
No, I mean, it's a very valid point. This is in the last year there have been several randomised studies of robotic versus non-robotic, and they really show no significant toxicity reduction. There is some recovery benefit, as you said, exactly that. But certainly overall survival seems to be the same. But then you'd probably expect that because both remove all the tumours, so why would they be any different in terms of survival? Because as long as the patient hasn't got metastases at the time of the surgery, both should be equally good at preventing the metastases coming.
Can you tell us a little bit about the Bragg peak you were talking about? Obviously, shaping that. Can you shape it?
Yes, you can. So Bragg peak, William Bragg, Cambridge physicist, protons come, it wasn't protons, it was particles, come into tissue and they gradually go through the tissue slowing down, and then suddenly they stop and they release all their energy in a little bundle at the end called the Bragg peak. Now, by putting different energies in, you can manipulate to what's called a spread out Bragg peak. So if the tumour, say, is 3 centimetres, many tumours are about 2 to 3 centimetres, you can get lots of little Bragg peaks covering, so you get a flat distribution across the cancer. And that's, again, all computer controlled, and there's something called pencil beam scanning, which allows you to scan the tumour with your proton beam. So William Bragg really identified what would become very useful for localized cancer treatment. Couldn't have been done without the imaging. You couldn't use all this stuff without. So the first proton treatment was in 1944 in California. No imaging there really, so it was trial and error. And that's the problem with any technology. There's enabling technologies that need to be there at the same time. Otherwise it's not going to work. I mean, so it's like the man that lost his keys on one side of the road, looks on the other because there's a light on there. It's the same thing with this. But yeah, the Bragg peak's very useful.
Carol, I'm interested in some of the numbers you said about, because I think you said about 20% of men who have radiotherapy would be suitable for proton therapy. My understanding, but you also said only 1 in 10 of radiotherapies overall would probably be it. So it suggests that prostate cancer is perhaps more amenable to proton therapy, which seems to go against where the NHS is at the moment, because they're very much focused on neurological cancers.
That's absolutely right. Basically, there was a study in 2012, a big study in the States that looked at what's called Medicare data, which is the over 65s get free care. There is a sort of NHS, but distributed mainly by the private sector for older people. And they looked at the returns, their financial returns, that's the problem. And they collected people that had prostate cancer, that had protons, conventional radiation, looked at the side effects, but only through the financial returns. And so you had to have it pretty bad if it scored you on as a payment on there. So if you had a stricture repaired, or you had some sort of minor surgical procedure, or you had severe incontinence, it would appear, but it wouldn't otherwise. So it's skewed data, and that seemed to show no difference between protons and photons. But that was in 2012, so the data comes from the previous decade. Now, it does seem that if you look at comparative planning, protons versus conventional on prostate, around 20% would benefit from protons in terms of the normal tissue sparing capacity of protons. And so that probabilistic equation is used in Holland now to predict who to give it to, who to give protons to. Here, the NHS is adamant that it's only 1%, so they have to take all the prostate has to come out of it, it can't be in there. And I would say, why not double plan and see what it is? The problem is that Christie is going to be, if you want to reduce the high cost of sending the children abroad, you have to treat them as soon as Christie opens later this year. And that'll fill it instantly. And then UCLH, it's probably 2021, although the public figure is 2020, but there's still a big hole in Tottenham Court Road. The only thing that gathers as you go there to look at it is the bird poo on the perspex window. So I think that it is an enigma to what to do with protons. And the title is, I think, the conundrum of protons in prostate. Do you open the gates, or do you say, no, we've got to do randomized trials? They're probably not the solution, because who would want, if you knew that protons looked better on the plan, like sparing your seminal vesicles, sparing the rectum, and so on. Would you want to be randomised to research? And there's no equipoise in that. It's essential in a clinical trial. You've got to believe that you really don't know the answer. If you know one arm's better, you should be offering that one arm. So these are all the problems.
Can I just ask one follow-up on that, which is, in order to do the plan, you need obviously some good imaging. Is the imaging sufficient now that you have confidence in those plans?
I mean, it's true that we really, the biggest problem in planning radiotherapy is knowing where the cancer ends and the normal tissue begins. And you know, it's got much, much better. I mean, when you think of me doing my plans with a stencil and an X-ray. But it's still, that's the area where, you know, artificial intelligence could really help there. The radiologist could use it to, looking at thousands of patients, to look at the criteria of where the cancer's actually ended and the normal tissue beginning. So that's going to come almost certainly and make our job a lot easier.
I have one.
George.
I was diagnosed 8 years ago with prostate cancer, and I was offered radical surgery or keyhole surgery. And as they've done only 3 keyhole operations up to my time, my GP was with me and said, I wouldn't trust a surgeon with an L plate on his back.
Good. And you're well, of course.
Yeah.
So question.
Can I come to this gentleman over here?
I was going to follow up on the other question. Given that such a limited resource available with proton therapy availability, how in practice are they allocating the resource, or is it postcode lottery? Assuming you're suitable. Right?
Yeah, no.
For example, if I needed it, would be better for my move box to ready.
That's the problem.
Better if you paid for it.
There's huge variability in access to healthcare, even in a national free system, which is puzzling. I mean, you'd expect it if you've got local insurance companies covering Oxford and another one covering Cambridge and London, and so you'd expect there to be variability. But the problem is that within the NHS, you can get the best possible care for cancer in the world. There's no doubt about it. But not everyone gets that, and why our data sets compared to Europe are poorer for many cancers. I guess, you know, even the NHS England, the children that are going, it's never been publicly spoken about. But what you can't understand, there should be 1,500 children going up. There are 1,500 cases make up the 1%, yet only 300 to 400 go abroad each year. And if you look at them, they tend to be mainly white, middle class, not the ethnic spread of Britain, and not the socioeconomic spread. And that's because the parents have fought to get it, and they've persuaded the consultant to fill the forms, they've persuaded the system to push for it. And the trouble with the NHS, the way to get better care is to gently push for better care. And so those that push get it, and those that don't, which is essentially unfair, but that's the way it is in the system. Because no one's interested in supplying the goods. It's not like a corner shop where the corner shop owner wants you to come and buy things off him. The NHS wants you to stay away, wants you to go to the pharmacy, wants you to use an app, wants you to use 111 because that's a lot cheaper than going to see a doctor. And a bit of the same here. Maybe I'm being a bit unkind, but it's dampening demand. And when there's new technology coming, whether it's abiraterone that we've heard about or proton therapy, it's best to use the 4 Ds of rationing, they're called. The 2 I can remember are denial, doesn't exist, can't be done, or delay, because people go elsewhere for the service. And it's a problem that we've had in the system and other public health systems.
Let's take one more question.
Yes, why isn't there much more research done on prevention? Like what causes prostate cancer?
That's a very good question. I was thinking maybe I should take my tomato, lycopenes are thought to be preventive, tomato skins and pure tomato puree. And there isn't much done on it. Prevention is very difficult. Almost certainly there are drugs that could prevent prostate cancer and natural compounds out there, and you could make them into drugs. I mean, a lot of the cancer drugs we have are natural compounds, vincristine, the periwinkle, Taxol, the yew tree, and so on. So we're not averse to using natural compounds, but you've got to identify them, and you've got to show that they're going to work. To show prevention, even in people at high risk for prostate cancer, takes years. Take 10, 20 years. The pharma industry is not too interested in waiting 10, 20 years to do that sort of research. Also, it's very dull to follow people up for 10 to 20 years. I remember a study where they were looking at high fibre diets for colon cancer. And the way to get the high fibre was a randomized study. You've got a bag of crisps, potato crisp, and you were randomised to get the high fibre crisp or the low fibre. And it had a marker, so you could do a urine test to see if you were taking the crisps every day. And it just ran out of steam because everyone got so bored. And I think that's the problem with this, that if we could identify compounds and use them in some model, then I think we could prevent a lot of prostate cancers. But people that are interested in preventing prostate cancer usually have symptoms or some things already not quite right and they want to do it. It's a difficult one. But you're quite right. Preventing cancer, probably 50% of all cancers are preventable by lifestyle change. No wine, no beer. I can see people drinking beer.
Well, doesn't it come down to be a political one, which is the people who would do the research of the drug companies?
Yeah, exactly.
They would go out of business.
Yeah.
Well, before we get into that area, not to mention diet, which we have discussed many times here in different ways, I think it's probably a good moment to draw things to a close. I have a feeling that Karol could go on all night talking about this subject. When you have the pleasure and honour of hearing a real expert talk about something that they know intimately with such good humour as well, you could feel in the room the attention and the interest in everything you've said. Thank you very much for that. And I can tell you, ladies and gentlemen, if you would like to hear or see a different side of Professor Sikora, you go along to the Chiltern
Princess Risborough Railway.
Princess Risborough Railway at Christmas, and you meet Santa on the Santa. Thank you very much.